Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the first in a series of 3 CMEO snacks. Our first CMEO snack is titled, Why New Treatments Are Needed for the Management of Psoriasis. The CMEO snack series is supported by an educational grant from Bristol Myers Squibb Company. I'm Dr. April Armstrong, Professor of Dermatology and Associate Dean for Clinical Research at the University of Southern California. I also direct the psoriasis program in the Department of Dermatology. Joining me today is Dr. Melinda Gooderham. Dr. Gooderham is the Medical Director at Skin Center for Dermatology and an Assistant Professor of Medicine at Queen's University. She is also Consultant Physician at Peterborough Regional Health Center in Ontario, Canada. Welcome, Melinda.
Thanks, April.
In addition to CME CE credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. In this 3-part series, we're excited to focus our presentation on some of the new data presented recently at the AAD VMX. Our learning objective for this CMEO snack is to address the burden of disease and unmet treatment needs in the management of psoriasis. So let's get started. As we know, the burden of disease in patients with psoriasis is well established. In fact, over 66% of patients report that they suffer in terms of engagement in normal social activities as a result of having psoriasis. About half of the patients oftentimes feel discrimination in the workplace, at school, as well as feeling socially distanced from other people as a result of having their psoriasis. Psoriasis affects their ability to swim as well as other exercise and activities. So as we can see, psoriasis has a tremendous impact on patients' quality of life. In some studies, while it's stated that about 3% of the patients express that psoriasis really affect their dating and romance, I think for me in clinical practice, the reality is probably much more prevalent than that. A lot of my patients, especially those who are younger and are currently, for example, seeking life partners, they oftentimes feel that psoriasis really hold them back in terms of what they can do with regards to establishing intimate relationships. Now, knowing that, Melinda, it would seem natural that more severe disease that a patient has, the more burden is associated with the disease. And what are your thoughts on that?
So actually, at the AAD VMX this year, there was some new data out about the burden of psoriasis, looking at the Corona registry, which is a wealth of information. And so what they did is they looked at special areas of psoriasis in patients with mild to moderate disease versus severe disease based on the BSA. So if you consider those with mild to moderate psoriasis as a BSA of 10 or less, versus severe psoriasis, which is a BSA of 10 or greater, you can see that the proportion of patients affected in these special sites, such as scalp, nails, palmoplantar, or genitals, was actually the same. So the same proportion of patients, whether it was mild to moderate or severe, had involvement of these special areas. And we know that these special areas come along with some extra burden for patients with psoriasis. And so they looked at pruritus, pain, fatigue on a visual analog scale. And although they did see that the scores were higher with severe psoriasis versus mild to moderate, there was also a substantial disease burden in the patients with mild to moderate disease as well. Even looking at the quality of life impact with a DLQI score of greater than 5, although higher with severe, it was still quite significant for those patients with mild to moderate disease. And I know that you were part of a poster that was also presented at the AAD with George Gondo on the factors associated with patient patient-reported remission in psoriasis. Can you tell us more about that?
So this study was conducted by the National Psoriasis Foundation, and we looked at patients, around 1,500 patients with psoriasis. And among those patients with psoriasis, about 40% of them report a BSA of 3% or less. And also at baseline, about 50% of them had used biologic in the past 12 months. And what we did was that those reporting 3% BSA or less were asked whether they felt their psoriasis was in remission. And then we looked at the factors that were associated with their perception of remission. So what we found was that of those who thought they were in remission, about half of them, over half of them, reported no impact in terms of their quality of life from psoriasis. And the mean duration of remission was about 60 months. And what was also found was that among those that are in remission, 65% of them were on the biologic, and vast majority were on some type of psoriasis treatment. And also, we did multivariable regression models to look at specific factors, patient factors that are related to remission. And what was found is that, and related to what I talked about earlier, that lower DLQI scores or lower impact, a lower negative impact on patients' quality of life was associated with remission, probably not surprisingly. In addition to that, if the patients assess that their global assessment of how they're feeling is also very, very good, that is also associated with remission. Lower body surface area, not surprisingly, was associated with self-perceived remission. Interestingly, female sex, so female patients were more likely than male patients to report remission, everything else held equal, and the use of biologics. Patients who were on biologics were more likely to report that they were feeling that they were in remission. Importantly, what was not associated with regards to related to remission were things like age, race, and BMI. Now, Melinda, let's pivot a little bit. In part 2 and 3 of this series, we're going to focus on patients with moderate to severe psoriasis. But sometimes there's a group of our patients whose moderate disease is beyond topical steroids, but they may not yet be ready for systemic treatment. What is new for these patients?
That's a great question. It's such a rich pipeline of new products that are coming for our patients. And there's actually some new non-steroidal topicals that are looking very promising. Some data that came out prior to the AAD this year on some non-steroidal topicals. So we have tapinarof, which is the therapeutic aryl hydrocarbon receptor modulating agent, that TAMA, that's always a mouthful, and then the PDE4 inhibitor roflumilast. So both of those non-steroidal agents showed at their primary endpoint about 40% proportion of patients achieving an IGA response. So an IGA of 0 or 1, clear, almost clear, with a 2 or greater improvement from baseline. So what we learned this year at the AAD was a little more about the patient's perspective, looking at PROs. So the Soaring 1 and 2, looking at tapinarof 1% cream once daily, we saw there was improvement in the 4-point improvement of the peak pruritus NRS from baseline to week 12. So about 2/3 of patients were able to reach that point of a 4-point improvement in the PPNRS. And we saw separation from the vehicle as early as week 2, which was the first time point measured. So improvement in itch with tapinarof. We also saw some post hoc analyses in the phase 2b study looking at improvements again at itch. We saw a benefit with a topical roflumilast cream compared to vehicle, improvement in itch, improvement in itch-related sleep loss, and also improvement in quality of life with DLQI. So not only are these non-steroidal agents meeting the efficacy targets of the primary endpoint with about 40% IGA response rate, we're also seeing benefit in itch-related sleep loss, and quality of life.
Great. Thank you for that wonderful summary. And let's continue that summary with our audience with our SMART goals to summarize this session. And I love SMART goals. They are specific, measurable, attainable, relevant, and timely. And so that is what we hope that audience will take away from this presentation to apply to your practice. And number one is we'll continue to appreciate how the burden of psoriasis affect patients' quality of life and negatively impact their participation in social and professional activities. We also learn to recognize that disease severity may not always drive disease burden. Finally, we also learn to evaluate factors that are associated with patient perspectives on disease burden. As I mentioned, this is the first in a 3-part series on psoriasis. Visit the Dermatology Education Hub on www.cmeoutfitters.com for part 2 and part 3. Don't forget to complete the evaluation and collect your credit for today's program. You'll be able to print your certificate from the platform. Thank you very much, Melinda, and our audience for joining me today. I hope the presentation gave you new insights into the burden related to psoriasis and some strategies to positively impact your patients.